Well, I chose 3 cases to discuss with you. Basically, they are not common cases, but I thought they were nevertheless important, bring an important lesson. This is an 84-year-old man who was recently referred to nephrology for evaluation of chronic kidney disease. Baseline serum creatinine is 1.3 to 1.5, but more recently it was observed in the low 2s, as you can see there. Past medical history is positive hypertension that was well controlled. A cancer of the esophagus was diagnosed in 1999. He had a status post-cisplatin and 5-FU treatment at that time. Paclitaxel, gout, and benign prostatic hypertrophy. Those were his history. There was no evidence at this time of any recurrent or metastatic cancer. He was on colchicine for his gout, finasteride, omeprazole, tamsulosin, and verapamil. Physical examination, he had a blood pressure that was well controlled, 123/73, and there were no other findings on the physical examination. In particular, there was no edema. The labs, the urinalysis showed no protein, no blood, pH of 5.5. The urine sediment showed few red blood cells, white blood cells, occasional oxalate crystals. Urine protein to creatinine ratio was less than 0.1. So that was the clinical history. And additional evaluation, the renal ultrasound was unremarkable. Glomerular disease panel, whatever that means, I don't exactly know what they did, but it was unrevealing. And the urine sediment appeared bland, but he had a significant rise in from the baseline serum creatinine. Colchicine and omeprazole were discontinued. He declined a kidney biopsy initially, and the empiric course of prednisone was started. The serum creatinine rose to 8.5 2 weeks later of this treatment, and he required hemodialysis. So here you have a first question. Let me see if I know how to do this. Would you biopsy this patient or not? So you can now vote. Not yet. Okay, now vote. Now you can vote. Okay. We stop now and let's see. Okay. Obviously, a pathologist, you wouldn't embarrass me saying not. Well, the biopsy obviously was done, and I will show you. Let me close this now. Click the slide. Yeah, I clicked the slide. Okay, here comes the kidney biopsy, and I'm going to ask you a question about the morphology. What is the most likely diagnosis once I show you the picture? I'm going to show you 4 slides, okay? So we will begin to vote now, but think of chronic kidney disease, not otherwise specified, acute phosphate nephropathy, gout with microtophus, hyperoxaluric state, or atheroembolism. Those are the choices that I will show you, okay? Okay, here's the first slide. Oops. That's okay. I cannot advance. Okay, here's the EM. Here is the light microscopy on the H&E. And this is a higher power on that area. Okay. All right. So now you get to vote, hopefully. No. Not yet? Now? Okay, now you get to vote. Do you think this is just chronic kidney disease, acute phosphate, gout, hyperoxaluric state, or atheroembolism? Okay, well, we better review the appearance of these things. In any event, 29% thought it was phosphate, 10% thought it was gout, 23% thought it was hyperoxaluria, and 5% atheroemboli. Okay, let me close this and click here. Okay, so these are oxalates. Oxalates polarize. You can only use the H&E to review this. Most pathologists don't know this because the PAS and the other special stains dissolve the oxalates because they involve an acid treatment of the section. So the H&E is the one that you need to polarize. And you see these classical pictures with the birefringence on the crystals. This is in the tubule, okay? So if this was atheroembolic disease, it would be in an artery, and I will show you some images of this, okay? So here you see how extensive the oxalates are. By light microscopy, you can barely see them because they are perfectly transparent, these crystals. So you have to go on higher power, as I showed you before, here, and then you have to use the polarized light. In my opinion, one of these crystals is enough to suspect hyperoxaluric state. I have looked at hundreds of chronic kidney disease patients and polarized them routinely on the H&E, even the nephrectomies from cancer patients, and you don't see oxalate. So if I see one oxalate crystal, especially in a small piece of tissue like this, you should suspect a hyperoxaluric state. I cannot tell you how often we make this diagnosis on biopsy without any clinical history of malabsorption or otherwise. Here you can see even in the cells of the tubules you have these crystals, small micro crystals. So it's not only the crystals in the lumen that do the damage, that there's also a particular form of injury to the cells themselves, just because of the high concentration of oxalates in the urine or in the tubular fluid. So widespread tubular oxalate crystal deposition, renal oxalosis, indicative of a hyperoxaluric state. The patient also had some lesions that suggested a vascular disease, probably from the previous treatment with cisplatin. Patients with cisplatin often develop a prothrombotic state. They develop endothelial injury, and therefore I think some of the chronic kidney disease in this patient may have been related either to pre-existing vascular disease or secondary to the cisplatin treatment. But there's no evidence of a primary glomerulopathy or immune complex disease. So as I mentioned to you, there is direct oxalate injury to the tubules. Not only is there obstruction and potentially interstitial inflammation, but some people think that the increased oxalates can cause direct injury of the tubules. Now in this case, hyperoxaluria, obviously this is not genetic oxalosis. There are 3 enzymes these days that have been identified in patients with the genetic disease. Hyperoxaluric states can be due to low calcium in the diet because we need the calcium to chelate the oxalates in the large bowel. If we don't have enough ingestion of calcium, the oxalates that are being produced in part by bacteria in the large bowel can be absorbed. And so the calcium in the diet, especially the excess calcium that doesn't get absorbed, is absolutely essential to control the amount of oxalates that get absorbed in the large intestine. So high intestinal calcium absorption, idiopathic hypercalciuria, is another condition that can be associated with a hyperoxaluric state. These are the more esoteric forms, if you want. Vitamin B6 deficiency also has an influence on the metabolism of the precursors of oxalic acid. And then the increased ingestion. And this has to do usually with either ethylene glycol poisoning, either willfully or by accident, or sometimes in a setting of homicidal ideas. Increased intake of ascorbic acid, vitamin C in particular, can result in this. Anesthesia with methoxyfluorine in the olden days when this was used as anesthesia, patients would die. Most of the patients with hyperoxaluria that I showed you on the biopsy have to do with enteric hyperoxaluria. And therefore, any disease with or without steatorrhea, some of these patients are completely asymptomatic, any form of intestinal insufficiency or pancreatic insufficiency is associated, it can be associated with hyperoxaluric state. And finally, just from increased colonic uptake of oxalates, you can also see this as a consequence of bile salts on the colonic mucosa. Now, there is another interesting aspect. Many times, the disease or the syndrome of renal failure is triggered in the setting of antibiotic treatment. And it has been shown that some bacteria in the colon can utilize oxalates. And those bacteria are sensitive to some antibiotics, and therefore, if you eliminate Oxalobacter formigenes from the stool, these patients can develop hyperoxaluric states. Now, remember, there is a lot of information these days on the microbiome and the influence of the bacteria in the bowel in several bowel diseases, and therefore I would not dismiss this possibility of causing a hyperoxaluric state. Remember, there are being, in some instances, in some conditions of the colon, they are even doing transplant of fecal material to reconstitute a more normal microbiome. And therefore, I think this is an important triggering factor, the history of the use of an antibiotic. So this can recur in the allograft, and therefore sometimes this is not diagnosed as the cause of chronic kidney disease. Here you have a case of post-transplant that was biopsied at day 10, and sure enough, what you have is distension of the tubules with massive oxalate deposits in a patient in which the hyperoxaluric state was not discovered pre-transplant. So this is kind of important, and this is why I thought you should know about this. Acute phosphate nephropathy can be seen in patients that in the past, when phosphates were used as cathartic for colonoscopy preparation, but even enemas with phosphate, fleet phosphosoda in particular, can cause sufficient uptake of phosphates that you can have an acute phosphate nephropathy. We have seen post-transplant acute phosphate nephropathy in patients with hyperphosphaturia due to an elevated PTH and sometimes toxicity of some of the proximal tubule toxicity. They have hyperphosphaturia. These patients get oral supplementation of phosphates in the form of episodic phosphate pills a day, and that is sufficient to cause sufficient injury in the kidney. And here you have what phosphates look like. They are basophilic. They stain with the hematoxylin in the tubules. You can see here these are crystals. They do not polarize as opposed to the oxalates. They are positive for phosphates by the Foncossa reaction, and they're positive for calcium by the alizarin red staining. So usually Foncossa is believed to be a calcium stain, but what it really stains is phosphates, okay? And here you see the phosphates associated with the calcium, so calcium phosphate nephropathy. Here you see the acute post-transplant nephropathy in a patient with a PTH of around 500. It wasn't treated beforehand, and this patient was given a small amount of phosphate supplements because of the hypophosphatemia and the danger of a potential muscle injury. So this patient developed, in the setting of supplementation of phosphates, in the setting of hyperphosphaturia, hypophosphatemia, developed an acute phosphate nephropathy, indistinguishable from what we used to see in patients with colonoscopy preparation. This is what the uric acid looks like. Again, the uric acid is soluble in water, and therefore it disappears. These are the crystals. These are microtophi, mostly in the inner medulla. I don't think I have seen ever a microtophus in the cortex. There's also a little bit of calcium here, as you can see, calcium phosphate most likely. So this is what urates look like. And finally, the crystals or the spaces of cholesterol left behind from atherosclerotic disease are usually in vessels. So you should look for where these spaces are, and in this case, atherosclerotic disease. Never mind this. So this patient hyperoxaluric state, I think it's an important aspect to consider, especially if patients get treated with antibiotics. I think in many of the cases that we have seen in the last few years, the trigger has been therapy with antibiotic. Okay, here's a second case. This is not so esoteric, by the way. These cases I'm showing you now are a little more esoteric, but mostly because I want to make you aware of potential associations here. 75-year-old man with metastatic melanoma seen in consultation in the emergency department with acute kidney injury. The serum creatinine from a baseline of 0.9 went up to 4 1 year ago. The patient had a cheek lesion diagnosed as malignant melanoma with a white excision 4 months later. 6 months ago, liver metastases were diagnosed on a restaging scan. Neck mass was consistent with metastatic disease as well. So he was given chemotherapy with ipilimumab and nivolumab, a protocol from the Cancer Institute. This is the particular protein. Do you know what this is? This is basically a checkpoint inhibitors. 10 days after cycle 2 of this combination of checkpoint inhibitors, the patient developed nausea, vomiting, fatigue, poor appetite, abdominal distension, edema, and he ended up in the emergency department as well. So here is the reason why this combination of drug of immune checkpoint inhibitors is being used. You can see the survival in this, I think this is month, with these is much better if you give the combination of these checkpoint immune inhibitors. So basically, with these drugs, you are revving up the immunological system by which it is hoped that the melanoma is being attacked. So this patient had the history of melanoma, as we mentioned already. In the urinalysis, the serum creatinine was 4, 2+ blood in the sediment, negative proteins, negative nitrates, and everything else was negative. The urine sediment showed 5 to 10 red blood cells and 5 to 10 white blood cells. Otherwise, everything else was negative. So I'm going to ask you some questions about which is the most likely diagnosis: interstitial nephritis, crescentic glomerulonephritis, myeloma kidney, diffuse lupus nephritis, or obstruction. Okay, I will show you several pictures here. Oh, wait a second. Oh, I don't think I'm going to show you pictures in this case. What do you think is the most likely diagnosis? Okay, you get to vote now.
Just click it.
Pardon me?
Click it.
Click it? Okay, I click it. Oh, yeah. Okay. Okay, the majority of you think the patient has an acute interstitial nephritis, and that is the correct answer, okay? This is relatively not that new an observation. Well, the urine eosinophils were negative, no peripheral eosinophilia, ANC and anti-GBM are negative. The serum protein electrophoresis and urine protein electrophoresis or immunofixation were negative. The light chains were normal in the ratio in the serum. The ANA was positive at 1 in 40. Double-stranded DNA was positive 25. Normal C3 and C4. The renal ultrasound showed 12 and 13.5 centimeter kidneys and no evidence of obstruction. Okay, well, let's see. Well, it comes anticlimactic now. We will not go through the question here. Obviously, you answered it right from the clinical perspective, but let me just show you what patients with this checkpoint inhibitor can present, okay? Okay, so here you have the cortex. You recognize because there are glomeruli here and here and here. and you see a sea of blue here. This is all small lymphocytes and other inflammatory cells infiltrating the interstitium. You can see that the glomeruli really are not inflamed, otherwise they would stand out in a background of normal tubules. So here it's the reverse of a glomerulitis. So here's the higher power on this. You can recognize some plasma cells here, these with the clear half here, the clear area. This is the Golgi apparatus of the plasma cells here, plenty of plasma cells. A few eos, here and here, here, and the rest are all lymphocytes and occasional histiocyte. So there is nothing unique to this except the association with these new biological elements. And this, I cannot emphasize this enough. Sometimes there is very little information in the literature about this. In this particular case, for this particular agent, we know that acute interstitial nephritis with tubular injury, as you see on this slide, is a known complication. In this particular case, there was nothing unusual in the infiltrate. These are mostly T cells, CD3 positive T cells, with cytolytic CD8 positive, and helper cells CD4. Very few CD20 positive B cells. So this is a T cell disease of the tubular interstitium, like most tubular interstitial diseases are. There are plasma cells, and there is a condition that you need to know about, and that I will discuss very briefly here. When we see that many plasma cells, we normally stain for IgG4. And you can see here the IgG4 has only very, very few cells. In patients with IgG4 disease, most of the plasma cells, or many of the plasma cells here, would be positive for IgG4. So these days, we always rule out IgG4 associated disease. IgG4 disease is a condition that is characterized by multi-organ involvement with pseudotumors, with inflammatory pseudotumors. Most often this disease was known in the setting of pancreatitis. Patients with pancreatitis have this disease. They can have inflammation of the salivary glands, with, again, pseudotumors, chronic kidney disease with interstitial nephritis that leads to rapid loss of function and scarring. Very often patients have retroperitoneal fibrosis in this setting, as well as other lower urinary tract involvement. Prostatitis is another, in man, important manifestation of IgG4 disease. The morphologic criteria for IgG4 disease is more than 10 IgG4 positive cells per high power field. This is a low power field, and we only see 2 or 3 cells. The others are non-specific staining of the vasculature. So this patient does not have IgG4 in spite of the fact that the plasma cells were very prominent. The other clinical criteria for IgG4 disease is hypergammaglobulinemia, and in particular hyper-IgG4. So if you have a patient with multi-system involvement, inflammatory process, multi-organ involvement with renal failure and hypergammaglobulinemia, or if you study IgG4 levels, high levels of IgG4, think of an IgG4 related disease. It's a systemic disease. It responds very nicely both to steroids and to rituximab. And these patients usually do very well, especially if the recognition of this entity is early. Well, this patient I discussed with you does not have IgG4 disease, but I thought it was important to show you this. The glomeruli in this patient is entirely normal, and therefore this patient has an acute interstitial nephritis, extensive, severe in the setting of immune checkpoint inhibitors. So what you do is you try to rev up the immune system so that the T cells attack the melanoma cells, but in the process you probably also rev up a lot of other systems. And whether this interstitial nephritis is due to the drugs that are being used, or whether it's due to another drug that normally wouldn't have caused interstitial nephritis, we don't know exactly. So this is what this patient has, a checkpoint inhibitor induced interstitial nephritis. In particular, he got this combination. So autoimmune diseases are not infrequent in these patients. Rash, 30 to 50% of patients have a rash on these drugs. This is usually a reticular or macropapillary rash, erythematous on extremities and or trunk. Patients can have colitis. Hepatotoxicity has been reported in 10% and less than 10%. And endocrinopathies, for some reason, failure of endocrine organs, in particular pituitary and thyroid and adrenal gland. And then, of course, in the kidney, you have the interstitial nephritis. As I mentioned, I don't know exactly whether these drugs cause the interstitial nephritis directly or if it is through indirect means due to revving up the immune system. This is from a Kidney International series that we collected over the last couple of months, actually. Acute kidney associated with immune checkpoint inhibitors. The case series has 13 patients with biopsy-proven acute kidney injury. As you can see, the median latency is 91 days. So between 21 and 245 days, the patient, after being exposed to these drugs, would develop the acute kidney failure. There is pyuria, white cells in the sediment. Protein to creatinine ratio is usually around 0.5 grams per grams. Other extrarenal manifestations are relatively high, 7 of 13%. And 4 of these patients, of course, because of interstitial nephritis, required renal replacement therapy. All of them, or 12 and 13, had an acute interstitial nephritis, and 3 of them with granulomatous lesions. And therefore, granulomatous interstitial nephritis should be considered. One should consider these associations if there is the history, of course, of the use of this. One case has a thrombotic angiopathy. The hospital course was treated with prednisone, as you can see. The initial improvement, but the serum creatinine rose to 7.3. This had a very bad outcome. This patient, eventually, the patient developed a rash and fever. He was readmitted with bloody stools, fever, a rash, Pseudomonas aeruginosa bacteremia was diagnosed, and eventually this patient died of septic shock 2 months after the last doses of this medication. So immune checkpoint inhibitors, I suspect once a certain combination of drug is used for one rescue therapy for one tumor, they frequently also get applied to others. So I suspect that you will see more of this, and we will see more of this in the future. Any experience with a show of hands? Any experience in the audience with acute interstitial nephritis due to these? Okay. Yes? Good. You have a question? Okay. So this is, I think, one of the complications that you can expect due to the fact that many new drugs are being used these days. Case number 3. Oh, we have very little time. Okay. This is a 48-year-old, we won't ask the question. A patient with hepatitis C, basically, and cirrhosis was initiated on a 12-week course of DAA therapy with sofosbuvir 400 milligrams and cineprevir 150 milligrams daily. The HCV infection was acquired at age 18. She had also idiopathic thrombocytopenic purpura and had a flare of lupus early in the course of this process. Remember, she is now 48 years of age. This did not recur. Eventually, she was listed for a liver transplant, and her baseline creatinine was 0.95. She developed some rash, dark red plaque on the upper chest, erythema and erosions around the nose and the cheeks, erythematous and edematous plaques on the lateral wrist and thumbs. So she also manifested systemic symptoms, increased somnolence, decreased energy level, lower abdominal and back discomfort, and dark urine. The laboratory showed a creatinine of 1.43, and the urinalysis showed red blood cells, white blood cells, and hyaline casts in the sediment. Her serum creatinine remained elevated, and for that reason she underwent a kidney biopsy. So this is, again, I think, something that you will see more and more as we use more and more these newer drugs in the treatment for hepatitis C. I will show you the biopsy. We will not go through the question. Here you see a well-preserved parenchyma, glomeruli. There is a little artifact of fragmentation. This was a CT biopsy, so it was very thin. But you can see there are glomeruli that look prominent. The tubular interstitium looks fine, except for some areas of atrophy, but otherwise nothing. Clearly a hypercellular glomerulus. You can see that there are thickened capillary walls here and proliferation of cells. So technically, this is a membranoproliferative pattern of injury. And you see the double contours very nicely here in most of the capillaries. And the proliferation mostly in the areas of the mesangium. Same here. So we will skip that. The IgG, very strongly positive, as you can see, in a confluent manner along the capillary walls. IgA is also positive. IgM is positive to a lesser extent. C3, C1q. So classic activation of complement with immunoglobulin deposits, what people have called a full house pattern. Kappa and lambda equally positive, so this is not some form of a paraprotein. We suspected that because IgG, IgA, and IgM were present. And numerous subendothelial deposits, as you can see here, with double contours and new basement membrane formed under the displaced endothelium. So this patient has a relatively severe form of lupus nephritis triggered by these antiviral substances or drugs. There was nothing special about this except that the patient had the use of these. And we collected 3 cases of this lupus-like immune complex-mediated glomerulonephritis in patients with hepatitis C virus infection treated with all-oral interferon-free direct-acting antiviral therapy. So again, something that you would not expect just from looking at what the drugs are supposed to do. Obviously, at this point, we have no idea how this comes about. This patient had a history of a prior episode of lupus, but she was asymptomatic since. The other 2 patients had no history of lupus whatsoever. So 3 patients with this type of therapy that triggered a rather sudden onset and rather severe form of lupus nephritis. Thank you very much.